So today we are going to have a vertical integration session on the topic anemia. For the same, I have eminent faculties from various medical disciplines which kind of engage with this topic. So I'll introduce the panelists for you. To my right, first is Dr. Subhash. He is a faculty in the Department of General Medicine. Dr. Deepa Madam from the Department of Physiology. Dr. Reema from Pathology, and Dr. Shobha from the Department of Obstetrics and Gynecology. So in this session, what we will try to do is we will try to discuss the topic of anemia mostly from the perspective of a second-year medical student, and try to see how the various departments represented here are going to add value to the core concept. So to start with, we have anemia. Once you go through the definition of anemia itself, you might find that there is kind of certain approach variations or perspective variations. So let us clear that first. I'll ask Subhash to kind of describe anemia or define anemia from a medical perspective.
First, anemia is basically a reduction in the hemoglobin and the hematocrit concentration in the human body, and we have different values for males and females. Usually what we take as anemia is hemoglobin less than 12 gram per deciliter for a lady, or less than 13 gram per deciliter for males, and a hematocrit value of less than 40 for males or less than 35 for females is also taken as anemia.
So that is more or less the numerical cutoff, but Deepa Madam, I think there is more to it, right?
So for anemia, we are discussing like decrease in the functional hemoglobin content. That may be either due to decrease in the total RBC count, or otherwise, if at all the RBC count is normal also, then the hemoglobin content will be reduced. That is our
Okay. So that kind of covers the definition. We will move on to the next question. That is to Dr. Deepa Madam. So Madam, can you just describe the steps of RBC hematopoiesis to start with?
Yes. So as anemia, if we are etiologically look upon, it may be due to decreased red cell production, or increased red cell destruction, or increase in blood loss. So first of all, we'll deal with the decreased RBC production. So we have to know about more on the RBC production, that is called erythropoiesis, the formation and maturation of RBC. Yeah. So first of all, where does it occur? Erythropoiesis happens. So it is differ for before birth, that is in the fetal life, and in adults after birth. So we are discussing on after birth. It is exclusively, normally it is exclusively from the bone marrow, that is from the red bone marrow. Okay. And the red bone marrow up to 5 or 6 years, it is all bone marrow is red. But afterwards, yellow bone marrow is also there. So the red bone marrow is will be confined only to certain regions, to the membranous bones like vertebra, skull, sternum, and only at the ends of the long bones, not onto the shaft. These are the sites of erythropoiesis. Now, regarding the different stages of erythropoiesis. So in the bone marrow, different stages of cells are there, not only for erythropoiesis, but commonly for hemopoiesis, for all the blood cells. The stem cells are there, then progenitor cells are there, then precursor or blast cells are there, then the mature cells. So regarding the difference between the stem cell and the progenitor cell, the stem cell has the capability to self-renewal as well as self-differentiation, whereas the progenitor cell will not have the capability for renewal, only differentiation only. So here in erythropoiesis, the stem cell is the the pluripotent, the parent stem cell, that is called hemocytoblast. That is common for all cells, not only for RBC. From that, it will be divided to form the committed stem cells. Two series of committed stem cells are there, that is the myeloid series of cells and lymphoid series of cells. So considering RBC, the committed stem cell is the myeloid series, that is otherwise called CFU gem. colony forming unit, GEM for granulocyte, E stands for erythrocyte, M for monocyte, and the other M for this megakaryocyte. That means except lymphocyte, all the other cells from the myeloid series of stem cells. Okay. That undergoes division to form the progenitor cell. Here the progenitor cells are called the colony forming units. So colony forming units means CFU. So in detail, before the colony forming unit, a large colony called burst forming unit having cells of more than thousands. It will be divided to form small colony, that is CFU. For erythrocyte, it is called CFUE. So this CFUE and BFUE together called the progenitor cells for RBC. Okay. Then it will undergo further mitotic division to form the precursor cell. That means the identifiable cell. Mm-hmm. So the first precursor cell for RBC is the pro-normoblast or pro-erythroblast. Mm-hmm. Then it undergoes division to form the next stage is early normoblast, then intermediate normoblast, then late normoblast, then reticulocyte. From that, the next mature to form the mature RBC. So what happens from this this pronormoblast to the mature RBC is that we all know the RBC size is only 7.2 microns. Okay. But the pronormoblast or the before that the stem cell that is having a size of more than 20 microns, 23 microns are there. Here it is a big cell with a big nucleus. But RBC is devoid of nucleus. Big nucleus and only a brim of cytoplasm. Okay. The cytoplasm is staining characteristic. It is basophilic. And it is highly mitotic. Then comes down from the pronormoblast to the later stages. Increase in mitosis so that the cell size become decreased, the nucleus size also decrease, but the proportion of cytoplasm will be going on increasing. At a particular step, that is in the late portion of the early normoblast, the hemoglobin start appearing. That under electron microscopy only we can see. In light microscopy we can see the hemoglobin in the intermediate normoblastic state. So that time the staining pattern also will differ because of the acidophilic this hemoglobin and the basophilic RNA presence. Okay. Then afterwards in the next stage again the cell size decreases and the nucleus becomes pycnotic, start to disintegrate, and late stage of the late normoblast the nucleus will be extruded out. Okay. And then it will mature to form the reticulocyte. In the reticulocyte stage, there will be remnants of the RNA. So, if we stain under the normal Leishman stain, we cannot identify the this one reticulocyte from the normal RBC. So, we will do other supravital staining like brilliant crescent blue. There we can see the remnants of the RNA as reticulum in the reticulocyte. So that way we will identify the reticulum and reticulocyte and reticulocyte counting we will do. And the importance of this reticulocyte is the reticulocyte count in the peripheral blood is an index of the erythropoietic activity taken place in the body. So it is important in anemia because if we are taking treatment for anemia, more erythropoiesis occurs. So that will be, we will be indicated as more reticulocyte in the peripheral blood. Otherwise, normally the normal reticulocyte count is 0.5 to 1% of the total RBC. That means in a smear, if we count 1,000 cells RBCs, we will come across hardly 1 or 2 reticulocytes normally. But that will be increased if there is more of erythropoietic activity in newborns and like that. Then that will be mature to form the our RBC having 7.2 microns, no nucleus, then mitochondria, ribosome, everything will be extruded and that one. And totally it takes around 7 days from the pronormoblastic stage to the normal mature RBC. So the final 2 days from the reticulocyte to the mature RBC. So 1 or 2 points regarding the factors affecting that is also important in point of anemia. So wherever we are in need of oxygen, that is in tissue hypoxia is there, that will stimulate the kidney to produce erythropoietin hormone, and that is needed for this erythropoiesis, and that will be also stimulated by the hormones testosterone, then growth hormone, corticosteroid, thyroid hormone, etc. So that is why in kidney disorders dysfunction, this erythropoietin secretion may not be that much there, and that will be resulting in anemia. Okay. Then other factors, that is dietary factors, all are needed for the production. That including we know the minerals like iron, copper, cobalt. Then more important, the maturation factors. That is the vitamin B12 and the folic acid. These are important for the DNA synthesis. So for the maturation. So if this mitosis if happen, then only the size will get decreased and more number will be formed. So if there is deficiency of vitamin B12 or folic acid, there will be maturation arrest. The mitosis will not take place properly. So the cell size also will be increased, and that is seen in megaloblastic anemia. Okay. Then another factor, interleukins are needed. Then another one, the intrinsic factor, the Cassell's intrinsic factor secreted from the parietal cells of the stomach, that is needed for the absorption of vitamin B12. So if there is a atrophy, a gastric atrophy, or either a gastric carcinoma or gastrectomy, all the cases, this deficiency of intrinsic factor is there, and that will resulting in pernicious anemia. Okay. So this much.
Okay, that has covered a lot of ground, ma'am, for us to base our discussion today. So I think just taking cue from that, Subhash, can you, from a clinical perspective, how do you classify anemia? Madam has already touched upon that. They can kind of build on that.
Yeah, usually, like what Madam had said before, we have a broad classification for anemia, and anemia can be broadly classified into 3 categories mainly. That is, there is a marrow production of red blood cells is damaged or destroyed. Second is when there is a reduced red blood cell survival. And thirdly is if there is a red cell maturation defect, like what Madam had pointed out. Now, under the underproduction in the marrow, it can happen due to either infiltration in the marrow or damage to the marrow, either due to infiltration due to some fibrosis like myelofibrosis, or where you have infiltration with some leukemic cells in the marrow, like that can cause anemia. Or there's marrow damage due to certain diseases where the marrow is affected, like in aplastic anemia. You can have underproduction of the red blood cells. And then we have the next broad classification is where there is a maturation defect of the red blood cells. The maturation defect of the red blood cells can be either cytoplasmic maturation defect or a nuclear maturation defect. The cytoplasmic maturation defects are usually iron deficiency anemia, or where there is thalassemia and sideroblastic anemia. And the nuclear maturation defects are mainly, like Madam had pointed out, that the maturation factors are required. There, vitamin B12 is most important, and folic acid deficiency. These both can actually cause maturation defect anemias. Then the third thing is whether RBC survival is reduced, either due to blood loss or due to hemolysis. And there is hemolysis, a very large group of anemias, and the large group of anemias where the hemolysis can be due to either intravascular hemolysis, or you can have fragmentation hemolysis due to prosthetic heart valves, or you can have metabolic defects in the red blood cells like enzyme deficiency, G6PD deficiency, or you can have hemoglobinopathies which are actually causing reduced RBC survival like sickle cell anemias. Or you can even have membrane problems in the RBC like hereditary spherocytosis, elliptocytosis, etc. And so this is a general broad classification of the anemias.
Okay.
Yeah.
Okay. Thank you, Subhash. Moving on to the pathological perspective, Rima, can you just enumerate on the RBC indices? Madam, wants to add anything?
No.
Yeah, please.
I just want to tell about the anemia during pregnancy. So,
Yeah.
as per the WHO classification, we take a hemoglobin level of 11 gram per deciliter as a cutoff. And the ICMR has graded anemia into mild, moderate, severe, and very severe anemia based on the hemoglobin levels. So, there is slight change when it
This
comes
is specific to anemia in pregnancy.
in pregnancy.
Okay, fine. Yeah, please.
I just want to add one more point in that underproduction of RBCs, like Madam had highlighted, when stimulation is reduced, so that can also cause anemia. For example, one of the most biggest examples is chronic kidney disease, where the kidney is not secreting erythropoietin, and we are getting anemia just because of that, as well as in chronic inflammation, secondary to rheumatoid arthritis or some other chronic inflammatory condition where the marrow is not getting stimulated to produce the red blood cells. That can also cause the anemia. So reduced stimulation is also one of the causes for underproduction and anemia.
Rima, can you enumerate on the RBC indices in CBC?
So CBC can offer several RBC parameters, including RBC count, hemoglobin, hematocrit, your reticulocyte indexes, and several RBC indices like MCV, MCH, MCHC, and RDW. So your MCV is basically the average size of your RBCs. So it is mean corpuscular volume, and the normal range is around 80 to 100 femtoliters. So anything within 80 to 100 will be your normocytic. Anything less than 80 will be microcytic, like in your sideroblastic anemias or iron deficiency anemias or thalassemias, and anything over 100 femtoliter is taken as macrocytic, like in your megaloblastic anemia due to B12 folate deficiencies, or other causes of macrocytic anemias like liver disease, alcoholism, or hypothyroidism, etc. So that is MCV. Then we have your MCH and MCHC, which are both indices of your hemoglobin content in the RBCs. So we have mean corpuscular hemoglobin, which is basically the average hemoglobin that is there in each RBC. So that will be like normal will be around 27 to 32 picogram, and that is calculated like hemoglobin by RBC into 100. So anything which is less than 27, you'll take it as hypochromia, that is reduced hemoglobin content in one RBC, and anything more will be hyperchromia. And next we have MCHC, which is mean corpuscular hemoglobin concentration, which is actually hemoglobin by your hematocrit into 10. So that is basically how much hemoglobin is there in 100 ml of packed RBCs. Then we have the RDW, which is red cell distribution width. It is the indication of how much anisocytosis is there in your RBC. That is basically the variability of your RBC sizes. In RDW can be measured, it's basically statistics, so either using standard deviation or coefficient of variation, that is CV or SD. If it is higher, that means your RBCs are of variable sizes, like for example in iron deficiency anemia, or you have or mixed nutritional deficiency, that is a patient is having both iron deficiency as well as B12 deficiency, so he's having microcytes and also macrocytes, so there's a huge variation in the size of the RBC. That is indicated by RDW, that is red cell distribution width.
Okay, thank you. So, moving on back to physiology. Ma'am, I think one thing which is of great clinical relevance is the oxygen dissociation curve. So, if you can just explain on that, it will be good.
Okay, so first regarding something regarding hemoglobin.
Yeah, hemoglobin molecule. And,
okay, so as you know, hemoglobin is a combination of heme and globin. So, globin is actually having four polypeptide chains, 2 alpha chains and 2 beta chains. And the heme is about 4 heme molecules are attached to each globin chain. It is having a porphyrin ring-shaped structure for a heme, and in its middle there is an iron molecule in the form of ferrous form iron, and for each ferrous form of iron get attached one oxygen molecule. So one hemoglobin can carry 4 molecules of oxygen, and one RBC contains how many hemoglobin molecules? 280 million hemoglobin molecules. So that much is the oxygen carrying capacity of hemoglobin. And also 1 gram of hemoglobin can carry 1.34 ml of oxygen. The previous one RBC contains 280 millions of hemoglobin. Here, 1 gram of hemoglobin can carry 1.34 ml of oxygen. That is also if it is fully saturated. That means all the hemoglobin is attached to 4 oxygen. Then it is like that. So, now coming on to the normal values and all are discussed. The reaction of oxygen with the hemoglobin. That is not oxidation. It is a loose bond that is called oxygenation. So whenever the oxygen tension PO2 increases, it will get attached, and that oxygenation, same way if the PO2 get decreased, it is easily dissociated from the hemoglobin. So that has one peculiarity. The affinity of the hemoglobin to oxygen is not equal or not proportionate. That is something more than that. That is, the interaction is called heme-heme interaction. That is, when the first oxygen attached to the hemoglobin, that time its affinity is little less. Afterwards, the affinity for the second oxygen will be still increased. And when the third oxygen attached to the hemoglobin, the affinity is more increased, and the most affinity for the fourth one. So that way it is going on. So like that, what is oxygen dissociation curve? It is a curve showing the relationship between the PO2 and the actually how much oxygen get attached to hemoglobin. That is indicated at a percentage of saturation, how much saturated with hemoglobin. That is directly proportional because more than 97 to 98% of the oxygen transport is in the combination form with the hemoglobin. Only 2% in the dissolved form. That doesn't mean that the dissolved form is not important, because the PO2 is contributed by the dissolved form of oxygen in the plasma. So as more and more oxygen is dissolved in plasma, the PO2 get raised. As the PO2 get raised, more and more oxygen will be attached to the hemoglobin. That is not directly proportionate. That is what I say. If that is directly proportionate, the oxygen dissociation curve, what you draw is a linear line. So we should know mathematically what is the difference between a linear one and a other than a sigmoid shape. So linear shape means both the y-axis and x-axis that should be directly proportional. It is now in the case of oxygen dissociation curve, it is not like that. In the lower PO2 level, that is from 0 to 10 millimeters of mercury, it is the oxygen affinity or the how much saturation is very low. Say if we show the graph, then it will be be more at 10 millimeters of mercury, the percentage saturation is 10%. But at 20 millimeters of mercury, it is not 20%. It is more than that. And up to 50 millimeters of mercury, it is not 50%. It is more towards 90%. Otherwise, if it is exactly proportional, it is like that way. So here P50, that is at a 50% saturation, occurs at a PO2 of 27 millimeters of mercury. So that way, if you plot like that, in the x-axis the PO2 and y-axis the percentage saturation, we will get a sigmoid shape curve. That means at the upper portion, it is almost flat. At a PO2 of after 120 millimeters of mercury, then no more oxygen saturation occurs. All the hemoglobin get attached. Now, after that, if at all, if we increase the PO2 at any more, we will not increase the transport of oxygen by combination with hemoglobin. only by, but in hyperbaric oxygen therapy, how we can increase the oxygen transport is only by increasing the dissolved oxygen. We know at the lung level, the PO2 is 95 to 100 millimeters of mercury. At that point, the percentage saturation is around 97, 98 percentage saturated. When we artificially give and increase the PO2 to 120 to 140 level, all completely it gets saturated, and if we can see, it is at a point of 100 percentage saturation. Afterwards, if we increase to how much, it is a flat only. We can't, because all the hemoglobin gets saturated. Like that, if we going on decreasing, when the blood reaches the tissue level, the PO2 is around 40 millimeters of mercury normally. At that time, the percentage saturation is around 60 to 70 percentage. That means the remaining, that will be dissociated. So that way it will be going up.
Suppose want to add anything on that, or no? Shobha madam, from in an OBGYN perspective, I mean, how relevant is anemia?
Regarding anemia in pregnancy, the whole, what we have already discussed, the factors applies to pregnancy also. But most commonly what we see is a physiological anemia of pregnancy. That is, there is an increase in the red cell mass that is around 18 to 20%. And there is an increase in the blood volume and plasma volume, which is around 40 to 50%. So the relative increase of the red cell mass is not as we see in blood volume and plasma volume. That results in hemodilution. So there is a physiological anemia because of hemodilution. Then the pathological causes, I think, which is we have already discussed, applies to us also. But the most commonest type of anemia, other than physiological, that we see is because of nutritional anemia, that is iron deficiency anemia. We do have folate as well as B12 deficiency, and we can have combination also dimorphic anemia. And then we can discuss regarding what specific to pregnancy. So we have in the first trimester we do have bleeding because of a pregnancy, the ectopic site, maybe if has ruptured. And then molar pregnancy, miscarriages. When we come to the second and third trimester, this antepartum hemorrhage, especially the placenta occupying the lower segment, we call it as placenta previa, and the premature separation of the placenta, that's called abruptio placenta, that also contributes to significant amount of bleeding and the drop in hemoglobin. Then immediately following postpartum, again, there is increased risk of hemorrhage, postpartum hemorrhage. So again, that also contributes to anemia of pregnancy. And then we do have this, worm infestations, then infections like malaria, HIV, then other inflammatory bowel diseases are also there. And the patients who have undergone gastrectomy, ileal resections, pernicious anemia, all those things also we do have, rarely we have cases. And then chronic kidney diseases, they present with anemia. And again, if we say regarding certain drugs like aspirin and anticoagulants can also contribute to anemia. Then inherited conditions that we commonly encounter is hemoglobinopathies like thalassemias, then erythrocytosis, sickle disease. And also hemolytic anemias can also occur because of certain viral infections, drugs as we already told. So that also contributes. Then very rarely malignancy can also occur in pregnancy, maybe genitourinary tract. Other than that also contributes to anemia. Then malabsorption syndromes are also included.
Thank you, ma'am. So coming back to Subhash, we have discussed a few points here. Just once you encounter a patient, like what are the key history and physical examination things you are looking forward in for workup of anemia?
Generally, anemic patients, they present with a history suggestive of symptoms of anemia. There is usually they'll have symptoms of breathlessness on exertion. They can have fatigue. Sometimes they can have giddiness, dizziness. They can have exertional chest pains. And if their anemia is very, very bad, very, very severe, they can even have cardiac failure symptoms like edema of the feet, swelling of the feet, and breathlessness. So when we get an anemia case, usually the first questions we ask is regarding the nutrition of the patient. So what nutrition they're taking, and generally if it is, we'll ask also questions regarding the blood loss, especially for ladies, whether they're having menstrual blood loss, what is the amount of menstrual blood loss, and for other elderly patients, whether they're having any other source of blood loss like blood in the stools. Some patients may come with chronic hemorrhoids and they'll have anemia, and some patients may have altered bowel habits. So such histories are important. And then we also have to ask important history regarding the drugs that the patient is taking, any medications which can cause anemia, as well as any history suggestive of anemia in the family actually. So if there is a family history of anemia, whether they are having some family history of some inherited conditions like G6PD deficiency, or whether they are having some hemoglobinopathies which are running the family, like for example thalassemias or the sickle cell anemias, where they might be having anemic symptoms, and but sometimes the family members will be aware of that there is an inherited condition going around in the family. And other important way anemia presents is as part of some other condition, where the patient is having either some underlying hematological malignancy. So they will present with symptoms of the hematological malignancy, like either anemic symptoms or symptoms of a neutropenia, where they might have recurrent infections, or they might have some bleeding manifestations like gum bleeds and nasal bleeds, epistaxis, and then we know that there might be some other disorder going on which is contributing to the anemia. Or we should also ask important histories, history of coexisting comorbidities, like for example chronic renal failure, and whether the patient is having some chronic disease like rheumatoid arthritis or other chronic inflammatory states which can also contribute to anemia, or some GI diseases like malabsorption syndromes or inflammatory bowel disease which can contribute to the anemia. So generally history is little vast. In the nutritional anemia part, we also ask very common histories about history of pica, that is whether they are having a tendency to eat raw rice or certain non-edible substances. If we get a history like that, then we are almost sure that the patient is actually having iron deficiency anemia. And another important dietary history which we ask all our patients, especially if anemia is there, is whether they are vegetarian or not. So if they are strictly vegetarian, not taking any milk or eggs or anything, then one of the first differentials we'll consider is whether the anemia is due to B12 deficiency. So this is how we generally take what anemia history. Examination, during physical examination, what we focus on is we look for pallor, and the most common site is we look for the lower palpebral conjunctiva and the mucous membranes of the mouth, tongue, and also the palmar creases. And in the palmar creases, we look for whether they are faint, especially if the hemoglobin is below 8 gram per deciliter, you might get a very faint palmar crease. And the other things we look for is if there's unexplained anemia going on, then we actually have to look for any features of whether there is any signs of any nutritional deficiencies, especially if we are suspecting B12 deficiency, whether there's any knuckle pigmentation or any CNS findings suggestive of a B12 deficiency, like reduced vibration of proprioception in the lower limbs, or absent ankle jerk with an increased knee jerk. So these are some CNS findings suggestive of a B12 deficiency. And we look for, especially unexplained anemias, we look for any signs that there is some other disorder going on. Especially what we are most worried about is whether there's hematological malignancies going on. So we'll be looking, we'll have a thorough general examination, whether there is any cervical, axillary, or inguinal lymphadenopathy, especially if it's large and significant, and the abdomen also, whether there's any hepatosplenomegaly. So if we get a lymphadenopathy or a hepatosplenomegaly with an anemia, we're more inclined to think of a hepatological malignancy as one of the causes. Or sometimes you might get anemia with a very, very large spleen. It might indicate some marrow disorder like a myelofibrosis. So if we get such clues on examination of abdomen and lymph nodes, then we'll be prompted to work up in that direction. And otherwise, this is what we generally look for in diagnosis. Then one important point is that in any anemia case, when we start examining, we might see some abnormalities. For example, there might be a tachycardia in the pulse. The pulse might be high volume. And if you examine the cardiovascular system, we are bound to get a forceful apex and systolic murmurs, especially mitral and aortic area. Very commonly, it's mistaken as organic burbus or valvular diseases, stenotic lesions especially. But actually, it's most of the cases, if there is significant pallor, all the burbus are actually just because of the anemia itself. So we don't have to run behind a particular valve diagnosis or a rheumatological cause. That's it. Thank you.
So coming back to the investigation parts, Rima, does peripheral smear play a role in anemia workup? If yes, can you explain more on that?
Yes. Peripheral smear is a very simple, easy and rapid, but yet it's a very powerful tool which gives a window into your functional status of the bone marrow. So in peripheral smear, you'll be able to see the morphology of red cells, WBCs and platelets. And to focus on red cells, first you'll have to see the size of the RBCs. And the size of the RBC is always relative to a small mature lymphocyte nucleus. So if it is equal to the size of a small mature lymphocyte nucleus, then it is normocytic. If it is lesser, then it is microcytic. And if it's greater, it is macrocytic. So next we come to the chromasia, that is how much the hemoglobin content in the RBCs. That is usual central pallor will be only 1/3. If it is more than 1/3, then you will call it hypochromasia, and then there is also hyperchromasia. And so in cases, and then you'll have to look for signs of any hemolysis, like are there any fragmented RBCs, schistocytes, or any RBC precursors like reticulocyte equivalent, which is seen in the peripheral blood, that is polychromatophils, or any nucleated RBCs are there or not. And in specific conditions like in thalassemia, you can look for target cells. In sickle cells, you can look for sickle cells and sickle cell anemia. And in membranopathies, you can look for spherocytosis and hereditary spherocytosis, or you can look for elliptocytosis and stomatocytosis, etc. And in enzymopathies, like for in G6PD deficiency, you can look for bite cells, hemighost cells, and Heinz bodies, and other inclusions like basophilic stippling and Howell-Jolly bodies, etc. And also look for parasitic infestations like Plasmodium, which is also intra-RBC parasite, which can also result in hemolysis and then anemia. And you can also look for agglutination, like cold agglutinin disease can cause clumping of the RBCs, and some paraproteinemias like myelomas can result in rouleau formation, which is the stacking up of RBCs. So we have to look not just at the RBCs, you should also look at your WBCs and your platelets. Like Sir told that you have to look for dysplasia, like in myelodysplastic syndromes. You have to look for blast in leukemias or any atypical lymphoid cells pointing towards lymphomas. Megaloblastic anemias can also have hypersegmented neutrophils, and also look at your platelet count also, because if there is pancytopenia, you can think of something hyperproliferative like an aplastic anemia or even a megaloblastic anemia. So peripheral smear, you have to focus on all the three lineages morphology carefully so that you can plan your next move.
Okay. So that's with the peripheral smear. Moving on to, is bone marrow again, bone marrow aspiration again something which we regularly do, or is it indicated in specific scenarios, and what are we really looking at?
So bone marrow is not done in every case of anemia. We'll usually do it if there is some atypical feature, like as Sir had already told in his clinical scenarios, in which you have to think about other causes of anemia, which could be not just a nutritional cause, or if there is heavy transfusion dependence and you're not able to explain the cause of the anemia is unidentified, or in the peripheral blood, if you saw some atypical cells or pancytopenia, and you want to look for the most, quantify the blast percentage, or myelofibrosis you want to look for, or myelodysplasia you want to look for, then all that you'll have to do a bone marrow. First thing you'll be seeing in bone marrow is your cellularity. Anything less than 25% age-adjusted cellularity will point towards an aplastic anemia or a hyperproliferative anemia. And then you'll also look at your erythroid colonies. Your erythroid colonies, they like if there is PRCA, there is pure red cell aplasia, then your red cells will be totally hypoplastic. So you have to count your number of erythroids, are they less or not? And if usually anemias, if your bone marrow is responding, that means there will be erythroid hyperplasia. So next you will also have to look at the type of maturation. Is it normoblastic maturation, or is it something like a megaloblastic maturation? And in such cases where your marrow is producing erythroid hyperplasia, but you are still having anemia, that could mean ineffective erythropoiesis. That means due to some reason your erythroids are getting apoptosis, and hence resulting in anemia. Then you can also use your marrow to grade your iron stores. Pearl stain is taken as gold standard for iron enumeration. So you can do a pearl stain and see the iron stores in your bone marrow.
And another investigation of interest would be of electrophoresis.
Yes.
Right? So where is it really indicated and how does it work?
So electrophoresis, basically your hemoglobin is composed of several, like ma'am told, the globin chain is made of alpha chain, is there beta chain, delta chain, gamma chain. So based on that, your hemoglobins are actually HB, adult hemoglobin is there, A2, HbA2 is there, HbF is there, like that. These are the normal hemoglobins. There are glycated hemoglobins like HbA1c, etc. So your hemoglobin is actually made of different proportions of these hemoglobins. So and each of these hemoglobins like HbA, HbA2, F and all have different physical and chemical properties. So based on their charge and mass and size, you can separate it by using an electrophoresis. That electrophoresis, basically anode is there, cathode is there, and you are putting an electrolyte and you're giving a uniform field of electricity. And so based on the charges, the hemoglobins will separate out into different bands. And we have already standardized it, and we know that where HbF will elute, where A will elute, where A2 will elute. So that way you'll be able to see how much proportion of your hemoglobin is made of A, how much is made of F, how much is made of A2. So we have specific places where it will elute, and we have the specific proportion of how much should be there in a normal individual. So in that way you will be able to see if there is any abnormal hemoglobin, like in hemoglobinopathies like thalassemia or sickle cells, or even unstable hemoglobins. Like for example, if its patient is a thalassemia major, then he'll have almost 100% HbF, which is alpha chain and gamma chain, because it's a beta thalassemia, so beta chains are completely absent. So instead there is alpha and gamma joining together to form HbF. Similarly, sickle cell anemia, you'll be able to see HbS peak instead of seeing the normal HbA peak. So in that way, different proportions of hemoglobin can be quantified, and you can find which is abnormal and make a diagnosis.
Okay. Thank you. So Subhash, we have touched upon the various investigations. If you can just summarize some investigations we have not, but can you just summarize the kind of a workflow or workup algorithm kind of thing for anemia quickly?
Usually when we get an anemia case, usually like what Madam had said before, we focus on the complete blood count first and the RBC indices, and depending upon the RBC indices, then another important investigation is like what Madam had mentioned, the peripheral Smia. And usually if we suspect that it's a nutritional anemia, we'll look for basically the MCV. If it is a microcytic anemia, whether MCV is less than 80 femtoliters, we'll be more inclined to think of iron deficiency anemia. And but there are other conditions which you can get a microcytic anemia, especially thalassemia is also one of those conditions, and that's where red cell distribution width will help us, and we'll look for the RDW. If the RDW is grossly increased, and in iron deficiency anemia, you might get also a reactive thrombocytosis. So a large RDW with a reactive thrombocytosis and a microcytic anemia, most of the time we are inclined to think of iron deficiency anemia. So then naturally, when we think of iron deficiency anemia, the next set of investigations will be iron studies, where we look for the serum iron, serum ferritin, then the TIBC, and the transferrin saturation. So that's the normal line of workup if we suspect iron deficiency anemia. And of course the peripheral Smia. The peripheral Smia will show, like what Madam had said, significant anisopoikilocytosis, and also once you get the iron studies, if the transferrin saturation is below 20%, normally it should be between 25 to 50%. If it is below 20%, we are confirming that it is a iron deficiency anemia. And ferritin will help us in that knowing what is the status of the iron stores in the body. If it is less than 15, usually we take it as significant depletion of stores in the body. Then the other investigations, when we look at the peripheral smear and the RBC indices, is we look for the MCV. If the MCV is high, we are thinking of a macrocytic anemia. Like Madam said, there are several causes for macrocytic anemia, but the higher the MCV goes, like if it's more than 110 femtoliter around, almost 99% of the time it's going to be vitamin B12 deficiency. So that we in our hospital actually luckily we have a B12 assay. It's not always hard and fast, but if you have the facility available, you can send a vitamin B12 assay, and if it's low, we can treat as a B12 deficiency. The other causes of acrocytic anemia can be folate deficiency, and since we have large alcoholic population also, CLD patients, alcoholism, hypothyroidism, all these are the causes for macrocytic anemias. Then the other way the smear helps us is that suppose we are not getting any very obvious straightforward cause for the anemia, then and in our clinical examination also nothing was forthcoming. Peripheral smear becomes very useful because sometimes it can tell us that something is going on in the bone marrow actually, especially if we see some abnormal blast cells, or if we see something called as a teardrop cells, which indicates that marrow infiltration is going on, either due to fibrosis, like in a myelofibrosis case, or due to hematological malignancy. Not all leukemias present with high counts, some present with pancytopenia. So sometimes the peripheral smear will show a vital clue. And another thing, how the smear helps us is by knowing the reticulocytes, whether there's any reticulocytosis. And then another set of investigations we do in the anemia workup is reticulocyte count, especially undiagnosed anemias, where we'll do a reticulocyte count and we'll find the reticulocyte production index. So reticulocyte count, first we do a corrected reticulocyte count, which is the reticulocyte count available for the lab into the hemoglobin of the patient divided by the normal expected hemoglobin, that is 15. That will give us the corrected reticulocyte count, and we have to divide it by a correction factor to get the reticulocyte production index. That correction factor depends upon the hematocrit value. If the hematocrit is around 25%, we'll take the correction as 2. So generally it's taken as if the reticulocyte production index is more than 2.5 or equal to that, the cause is probably a hemolytic cause or a hemorrhagic cause, and if it's less than 2.5, it could be a maturation defect or a hyperproliferative anemia. So if you're getting a very high RPI or reticulocyte production index, then again the smear is going to help us, especially if it is showing some evidence of hemolysis like a schistocyte or a helmet cell, that we are actually inclined to think of a hemolytic cause. Then we will start working up for hemolytic causes, especially if nothing is very obvious like a hemoglobinopathy or enzyme deficiency, then we might have to think of autoimmune hemolysis. That's when we start sending our direct Coombs test and indirect Coombs test and those sorts of tests. So generally with the clinical picture and the RBC indices and the peripheral smear, we go for the next step here. And suppose the bone marrow, the smear is showing something suspicious, then that's when we actually go for the bone marrow. And the bone marrow will tell us whether there's something like anaplastic anemia going on, or like Madam had said, a myelodysplastic, especially elderly patients, unexplained anemia. Sometimes it can be a myelodysplastic syndrome, and nothing will be there on the clinical examination or on the labs actually. And sometimes a macrocytosis maybe. Otherwise, sometimes only a single cell line might be affected. So myelodysplastic syndrome, and sometimes rarely even the hematological malignancies like leukemia. Before that's where the marrow helps us actually, undiagnosed anemias. Thank you.
Thanks so much. To Shobha Madam, if you can tell something about HELP syndrome, it will be of great help.
Yeah, HELP syndrome, from this name itself, the H stands for hemolysis, then elevated liver enzymes and low platelet count. So it is considered as one of the severe form of preeclampsia, or some even say it's a variant of severe preeclampsia. So as you know, the preeclampsia, the condition that occurs during pregnancy after 20 weeks, and there will be elevated blood pressure of systolic of 140 millimeters of mercury and diastolic of 90, and there will be associated proteinuria also. So what is happening in pregnancy is normally the maternal spiral arterioles, they are actually high resistance, low capacitance vessel. So in pregnancy there is remodeling occurs, so that there is a trophoblastic invasion occurs. So there are 2 waves that is completed by around 16 to 20 weeks. So by this trophoblastic invasion of the maternal spiral arterioles, it is converted into a large capacitance, low resistance vessel, so that the blood flow freely from the mother to the baby. So if this doesn't happen, this result in preeclampsia. So as we told, it's a HELP syndrome is a variant form of severe preeclampsia. Apart from that, the pathogenesis they say is there can be a defective endothelial apoptosis also. So as a result, what happens is that there is more of a release of the inflammatory cytokines. So the vasoconstrictors or the vasospasm causing like thromboxane, A2 and serotonin. And as a result, there is what happens is that the platelet, they get adhered and there is aggregation. And because of this, to this damaged endothelium, as a result of this ischemia and perfusion injury, the small RBCs, when these RBCs pass through these damaged vessels, they are damaged. And as a result, there is microangiopathic hemolysis occurs. So this is what is happening in HELLP syndrome. And usually it is seen in multiparas and after 27 weeks, that is in the third trimester. But there are cases reported even immediately after the postpartum period, up to 1 week, just like for preeclampsia. And especially after 48 hours also, it can happen. That is 1/3 of the cases. So, and we have a few differential diagnoses also, like we have to think about fatty liver of pregnancy, because there is a long chain fatty acid coenzyme dehydrogenase deficiency is there. So these intermediate metabolites from the fetus goes back to the mother and thus causes again inflammatory changes. So that can also contribute to HELLP syndrome. So this is in general about pathogenesis. So then you have other differential diagnosis, as we can take severe preeclampsia, SLE, then TTP, HUS also comes into the picture of HELLP. So again, we do have classification, how to classify this HELLP syndrome. So the two classifications, one is Tennessee classification and other is the Mississippi. So in Mississippi, they are again categorizing based on the platelet count. So according to Mississippi, there are 3 types. The type 1, we have severe case, that is the platelet is less than 50,000. And type 2, it is around 50,000 to 1 lakh, and between 1 to 1.5 is in type 3. Then as we told, the marker of hemolysis is the LDH. It is elevated twice normal. So it's more than 600 international units. And the LFTs, so the AST-ALT will be twice normal, around 70 and above. So this is the criteria that we use to classify. And again, Tennessee classification also is there, where we classify into partial HELLP or complete HELLP. The parameters are the same. Here the platelet is less than 1 lakh. We take into consideration for hemolysis the bilirubin level of more than 1.2 milligram per deciliter, LDH of more than 600 international units, and again, anemia also is taken into consideration. So with this classification, we can either 2 is present. If all the 3 are present, it is complete. So the main importance of what you have to give for HELLP syndrome is, it is you have to interfere as early as possible. That is the most important thing. So the management depends upon one is the gestational age. So if it is once the period of viability has crossed, the decision is easy for us, so that we can immediately terminate the pregnancy. So the question comes whether that is after crossing the viability, that is 24 weeks till 34 weeks. That is the area where most of the babies born preterm, they will have like preterm complications. So now what to do? So after 34 weeks, it is easy for us, immediate termination can be done. But in between this 24 and 34 weeks, what comes is then we have to think about the fetal prematurity. So we need to add few drugs to the mother, like corticosteroids for lung maturity. And then also magnesium sulfate for neuroprotection. And also magnesium sulfate helps in form of severe preeclampsia to avoid eclampsia also. So if we have a time, we need to give the supportive care for the baby. If we don't have, then we have to immediately terminate the pregnancy. Then stabilization of the patient. So what all parameters are abnormal, we need to correct. Mostly the HELLP may end up in DIC, mostly. So we may have to correct the clotting abnormalities also. So once the HELLP is diagnosed, the treatment is termination of pregnancy.
Thank you, ma'am. It's not possible for us to discuss all the management of all different types of anemia, so we'll be just touching upon a few. Again, to Shobha Madam itself, if you can just discuss how do you manage iron deficiency anemia in pregnancy, anemia in pregnancy?
Anemia in pregnancy is managed according to, one is the gestational age, second is the degree of anemia. So I've told initially the ICMR classification. So it's severe is less than 7 and very severe is less than 4. And the type of anemia. So coming to iron deficiency, which is most commonly seen, so we take into consideration the gestational age. If it is severe anemia, irrespective of the gestational age, you need to transfuse Paxil. So otherwise she will have problems of cardiac failure. So you have to transfuse irrespective of the period of gestation. So coming to mild and moderate, it will be sufficient that you can give oral iron supplementation in the form of ferrous sulfate, fumarate or gluconate. So the elemental iron for one tablet is usually 60 milligram. So maximum you can give 3 tablets in a day. So a woman who is not able to tolerate oral iron or having malabsorption syndromes, you may have to go for parenteral preparation, where you have the newer ones. We go for sucrose, and carboxymaltose, which is having less complications. Previously and all, IM injections were given, that is not being preferred nowadays. And there are a few cases of refractory anemia where are not responding. So we will have to rethink about our diagnosis. Then, as Madam told, you have to go for a bone marrow biopsy if indicated. Then there is another thing is the recombinant human erythropoietin. So that is, the studies have shown that it is found to be safe for both for the mother and the fetus. So especially it is useful in a refractory anemia. Then you have Jehovah Witness, whether refuse blood transfusions in case of severe anemia. Chronic kidney disease, which will respond very well to erythropoietin. So again, erythropoietin also has a role in pregnancy. It can be safely used. That's what few studies have showed.
Okay. Coming back to Subhash, can you just touch upon the management of nutritional anemia and also the broad principles of management in anemia?
Generally, our management of anemia, it actually depends upon how symptomatic the patient is. And usually, suppose the patient is having a very, very severe anemia and he is having symptoms suggestive of cardiac failure. Examination findings also suggest of cardiac failure. If the patient's JVP is elevated, there is edema, bilateral basal crepitations, and patient is having severe anemia, then usually below 8 gram per deciliter, and patient is severely symptomatic, we usually directly go for blood transfusions actually, especially if we are sure that there is no other obvious cause like hematological malignancy or other things. We will go for a blood transfusion and we'll give a packed RBC transfusion till the hemoglobin crosses 8 gram per deciliter. But if the patient is not severely symptomatic, not showing features of cardiac failure, then we have more time to wait actually. So we can actually go for especially in iron deficiency anemia. If we find that like I said before, if the transferrin saturation is below 20%, then we can go for iron supplementation. That can either be in the form of oral iron, like what Madam had said, each tablet contains 60 mg elemental iron. So per day we need around 200 mg elemental iron for the supplementation. One thing we should remember is that we would give it thrice daily. Many times mistakes which happen is it's being given once daily or twice daily, but that won't be sufficient. So if a patient is having a low hemoglobin, you have to give it thrice daily. And the problem is that iron is a very notorious tablet to cause gastric irritation. So many patients won't tolerate oral iron. So we can give, if you're giving oral iron, you would give it, and once the hemoglobin becomes normal, that is if it crosses 12, we have to actually continue the iron tablets till the iron stores are supplemented. So that will take another 3 to 4 months or maybe even up to 6 months after the hemoglobin is normalized. And you have to continue the same dose till the iron, otherwise the anemia is going to recur as soon as you stop the iron deficiency, iron tablet supplementation. Another thing you should remember is that our population actually has helminthiasis. So usually the first day we supplement with albendazole 400 mg dose also, especially iron deficiency. And if the patient is not tolerating oral tablets at all, since many patients don't tolerate, like Madam had said, we have newer iron preparations like ferric carboxymaltose. So usually we calculate the iron deficit, that is patient's body weight into 2.3 into 15 minus the hemoglobin of the patient, and we add 500 to 1000 mg for iron stores. So usually roughly if a patient is having around hemoglobin 8, we get an iron deficit of around 1000 to 1500 mg. So one ferric carboxymaltose around 500 mg. We can put it in 100 ml saline and give it over half an hour or 15 to 20 minutes or half an hour, and we can repeat the doses maybe every 2 or 3 days. And usually over 3 or 4 doses, the 1000 to 1500 mg of iron deficit will be sufficiently neutralized. So that's one way we can do it. Then the other ways, many places ferric carboxymaltose is not available, so we go for iron dextran actually. That usually we can't give such a high dose. Only FCM we can give 500 mg. Otherwise, for iron dextran you can go. You can give 100 milligrams and we give it maybe over 3 or 4 or 5 days. The problem with iron dextran, older preparation of iron is anaphylaxis is the risk. So some patients may get anaphylaxis. So if you get any patient having chest pain or breathlessness or BP fall during an iron infusion, immediately the infusion has to be stopped because the patient is going into anaphylaxis and you might not be able to give it again. Then the other thing is that CKD patients also, before we give erythropoietin to stimulate this, we'll check for iron deficiency. If iron deficiency is there, then we have to supplement the iron first. So many dialysis patients will receive 5 to 6 doses of iron dextran or ferric carboxymaltose till, and once the iron is supplemented, then the erythropoietin is started, so that the stimulation can also work with the background iron replacement. Now, if the second side, if we are seeing a macrocytic anemia and the B12 levels are low, or we feel that it's a B12 deficiency, especially with the knuckle pigmentation or neurological manifestations, and then we can go for vitamin B12 injections. Usually 2 forms are there, hydroxycobalamin and cyanocobalamin, and usually we give 1000 microgram injections IM daily, or even IV can be given. Here we are giving IV, and usually the dose is 1000 microgram daily for 1 week, followed by once a week for 1 month, and then once a month for 1 year, to continue the maintain the stores also. And sometimes in textbooks they have written as 1000 micrograms IM once every 3 or 4 days for around 10 doses. But IM, many patient populations don't prefer IM because of the difficulty of administration, and so usually we go for IV administration, and that is found many times to correct the deficiency in terms of correction of hemoglobin as well as the neurological deficit. And actually severe B12 deficiency with low hemoglobins of 3-4 around, maybe you might not need to transfuse also. Even just B12 deficiency supplementation within 1 week, we see a dramatic response if the cause is B12. And always we supplement folic acid also around 5 milligram daily, especially if it is a macrocytic anemia, so that never supplement folic acid alone, because sometimes there are case reports of cobalamin deficiency neuropathy worsening with folate supplementation. So if you're giving folic acid, better to give B12 also if it is a macrocytic anemia. So that's how we usually go for a...
regarding dietary modifications, so that is more of heme iron containing diet, and then citrus fruits, then iron containing utensils you can cook, and then during pregnancy we give iron and calcium. So most of the patients we take it together, so we have to tell them specifically you need to take it separate timings. And then like phytates, phosphates, tannates, all those presents in this vegetables and all that also he will hinder the absorption. So that also we have to tell them that during the time of taking intake of iron tablet we need to restrict, like not restrict, it should not be taken at the same time. So the few dietary modifications also it helps, apart from, as you told, deworming, that also has to be considered.
That nicely sums up the management principles. So we started off with physiology, and I will end the session also with physiology. So, ma'am, what happens to an aged RBC? Like, how is the destruction process, and what is its relevance?
I think in the context of hemolytic anemias, it is important maybe. So normally, consider the lifespan of an RBC is 120 days, we know. But before that also, due to hemolysis, it can rupture. Usually, while it is passing through the splenic capillaries, it will happen. And it will hemolyze and hemoglobin will be released. So, suppose if it is before it reaches the spleen also, if hemoglobin is liberated, the transport protein haptoglobin will take up the hemoglobin to the spleen, and the future things in the spleen happens. So the hemoglobin, it will be split up into again heme and globin. What happens to globin is it is taken back into the amino acid pool and it will be used for recycling. Then the heme, it undergoes an oxidation reaction. An oxidase enzyme will convert it into, separated into iron, Fe, and carbon monoxide get released, and biliverdin is released from that. This iron, again, it will be taken up by the transferrin and it is stored as ferritin. Then the remaining things, biliverdin. Biliverdin, that is a straight chain. The pyrrole ring is separated and it forms a straight, not ring, it's a straight chain. That will be undergone reduction by an enzyme biliverdin reductase and forms our bilirubin. Okay, so bilirubin, that is formed in the spleen, but it is water insoluble. So it will not be transported. So it will be in combination with the albumin will attach to that, and that albumin bilirubin complex, that is called unconjugated bilirubin, that is transported, and as it is a bigger one, it cannot pass through the kidney. It will not be excreted through the urine. It will, when it reaches the liver, it will be taken up in, and the albumin get separated. Then it will undergo conjugation reaction and form bilirubin diglucuronide, that is the conjugated bilirubin. That can pass through the urine. So this thing will be excreted into the bile, and through biliary circulation it will reach the intestine, small intestine, and some of it will be enter into the general circulation, and some bilirubin, this conjugated bilirubin, can be excreted through urine, and some undergoes again enterohepatic circulation. Then the remaining portion will be coming to the small intestine and large intestine. It form urobilinogen. That also, urobilinogen also go into the general circulation and can be excreted through urine, and the remaining portion comes into the large intestine, and bacteria will act upon and form stercobilinogen, that it will get oxidized and give the usual color to the stools. But now the thing is hemolytic. When there is more hemolysis, there is more formation of unconjugated bilirubin. So that will not be excreted. So the urine bilirubin is normal in that case. That is what regarding.
Okay. Thank you, ma'am. So thank you all. And I believe this discussion would have given a holistic approach or holistic understanding on a complex topic like anemia. Thank you.